And in the 10 years of me practicing, it's just been so many women that come in to see me, sort of surprised, taken aback, and feeling lost about how to manage their health, especially at times of hormonal transition in their life. And so I've become particularly passionate about helping women navigate the midlife transition, perimenopause and menopause. And so, honest to God, other than me just loving talking about this, it is, if I can help more women have a more knowledge, more access to resources around this topic, and I can help women feel better, because you can feel better if you're not feeling well or yourself. There's so many options that women can be presented with. And ultimately, I believe with a foundation of awareness and knowledge that I just feel in my 10 years of practice, I've seen there's some really big gaps that exist there. So that's the point of this. I am not a woman in perimenopause or menopause yet, but I am a woman, and I will be there sooner than later. So I'm not sitting across from you today as a woman that has personal firsthand experience, but as I say, in the 10 years of practice I've been in, it's such a common concern. And I guess I'm seeing more of the women that come in with it being a challenging time. I have seen women that sail through it as well, but regardless, there's always a lot of questions around it. And so I just feel more women deserve to have more information, and transparent information about it. And so just, I'm gonna ask a few questions maybe as we go. And what I'll do is, if you know how to raise your hand on Zoom, there's a button where you can raise your hand. You can do that and let me know that you're there and listening, and you can use the chat as well. And I will check that at the end and take some questions for sure. So, okay, so menopause and perimenopause 101 is the topic today. And yes, this is such a big topic. I pitched to Lori, let's break it up into 3, and we'll do them a bit spread out, because I feel that there's a certain amount of information that women deserve to have, and it needs a bit more time to get through it. So we're starting with the basics today about what is menopause, what is perimenopause, what's the difference, how do I know which stage I'm in. We're going to talk a bit about what are the basics of what your hormones are doing for you and how they really change throughout these transitions. We're going to talk about hot flashes and some other pronounced symptoms associated with menopause, and even some strategies around how you can support yourself and manage those symptoms. And then we're also going to talk a bit about testing. Is this something that you need to test for in and of itself? And we're going to wrap it up. I did want to share some information about hormone replacement therapy today, because I do get a lot of questions about that. And once again, I just feel like it's something that women need more information on, so that they can consider it as part of an informed decision-making process with respect to their care. So let's jump right in here. So the first couple slides, I mean, maybe this is the quintessential image you think of when I say menopause. If anyone wants to chat, type into the chat right now. When I say menopause, you say what? Like what's the first word or experience that pops into your head? There's someone in the chat. I'm just gonna check it here. Hot flashes, yeah. I mean, even I put the picture up, but it's considered a hallmark symptom. So this is literally pulled from, like, if I put in menopause into Google Images, this is what comes up a lot of the time. So it's this sort of assumed image associated with this hormonal transition. And to be honest, I don't love it. I feel like we should be trying for a new image, for sure, but this is one that's not uncommon. And yes, we will talk about hot flashes. So people are saying other things. They're saying irritability, they're saying headaches, old, they're saying brain fog, nervous about it. Thanks. I love when you guys just chat with me. Surely it can't be worse than PMS. That's bad enough. Good point. Well, so the questions around like worsening PMS, we're going to talk about that as part of perimenopause. Once again, it's all reflective of a sort of continuum of some hormonal fluctuations and changes. And once again, I want to help you understand, how can you identify where you're at in this process and advocate for yourself in light of it. So, okay, so here's this classic image of women being hot. This is another thing that I found. I can't take credit for it. It's from this site that's on the right-hand side. If anyone wants to yell bingo, I'll just give you a minute to read over it. And in no way am I'm not trying to, joke or, really truly make light of this, but I just thought to kick things off, break the ice a little bit. If you keep sort of chatting and saying like, bingo, yeah, got it. At least, the one thing I would say is you're not alone. You're in the company of other women here that are experiencing a lot of these different changes. I don't know. I thought, based on what women tell me, these things can definitely come up. Design bedside rain barrel to collect night sweat runoff. Hoard Super Plus tampons. Flip off gravity. Ha ha ha. Yeah, it sounds really fun, right? And ultimately, in the end, I want you to not feel like perimenopause and menopause needs to be synonymous with suffering. It does not. It does not. Yeah. Anybody got a bingo? Pea sneeze, not fun. No, not fun. And sometimes these things happen to younger women as well, but this was created for the woman in her 40s or 50s. Okay. This picture here, I've always loved this picture. I've known about it for years. I feel like I've shared it a few times. As I say, like, I don't want to make light of these symptoms because so many women come in and describe the last two slides to me and they don't feel themselves. They feel out of control. It's really uncomfortable. It's really disruptive to their day-to-day quality of life. And it upsets me when women come in and, they don't know who to talk to about it. They've gone to the internet first. Maybe they have gone to their doctor and they just haven't gotten, a real conversation or many options presented around it. Maybe they have, right? It just depends. And I feel like I see a lot of women that are slipping through the gaps there. And it starts with just like awareness of like, there are so many different ways to manage the symptoms of perimenopause and menopause. And, it means that someone needs to take the time to understand what's going on for you and what might be the best way to support your health and well-being in the short and in the long term. So I'm passionate about giving women their superpowers back, helping them feel better and feel their best. And then you can realize your full potential. And I'll say this again at the end of the slide deck, but I literally feel like women at midlife are holding up the world. I literally believe that. And too many of them are not feeling awesome. And I believe if more women feel better and feel their best, and don't feel like these hormonal changes are getting, the better of them, then they can put themselves out into the world in the best way possible. And so if I feel like if I can do that in a little way, in my little day-to-day practice here and, doing things like this, then that's great. So let's get your cape back on. There was a study done a couple years ago, a doc in the States, I believe, or maybe in the UK, this doc, Sarah Jarvis, she surveyed a whole bunch of women across the globe and she summarized the results by country. But some of the summary, just making the point that menopause is not talked about still a lot. Like is it taboo? I don't know. It's just not being talked about a lot. It's, you can see 70% of women surveyed said they had no one to talk about perimenopause or menopause to, up to almost 50% of women felt completely unprepared. The same amount of women felt unprepared for menopause, meaning like symptoms start happening or body changes and they were like, I don't know what's happening. And that can make it even more stressful and disruptive. Up to 40% of women didn't know the difference between perimenopause and menopause, and that's totally fair because who's telling us about this? Once again, if you want to raise your hand or sort of, I can't see those hand raises, but if you want to put in the chat, like if you feel, anyone here know for sure, like I am in perimenopause, or anyone know for sure I am post-menopausal, I mean, this is, once again, we're going to navigate this question, but a lot of people, it's not uncommon for women not to really know and come in asking questions. So there's just a lot of evidence that there's not a lot of information being shared around this. And once again, I would argue, and it's my deep belief, that we need to talk about this more because more women than ever right now are in perimenopause or menopause, and more women than ever are living longer in a post-menopausal state. And an interesting fact that you might not be aware of is that no other mammal other than humans and whales live half their life in a post-menopausal state. No other mammal. And so we're like, women are going to live a long time, you know, in a post-menopausal state. And so there should be a lot more conversation around how to optimize women's health. There should be a lot more research around it because women are not, you know, just little men. There's a lot of bias in the medical system around health research. I mean, I'm being a bit of a feminist here, but males' sexual dysfunction or things that come up there, so quick to be treated, right? And way more research. Whereas for women, it's not the same at all. And I don't like that about it. I'd like to think it's coming around, but you know, it's not equal and not talked about and not addressed. So there was a question about unsure about the perimenopause versus menopause. You're guessing it goes by age. There are averages around age, but it really depends on what signs and sort of symptoms you might be experiencing. So we're gonna get into that next. So let's define the stages technically. So this is out of the North American Menopause Society, which I'm a member of, and I'm studying to take their exam in the summer and be a certified NAMS practitioner. They're great. They do a lot of advocating with respect to research and whatnot. Someone's just got muted. I'll ask everybody to just make sure that you're muted.
But it's too soon to, obviously we've got to prioritise the move.
Okay. I'm going to ask everybody to be muted. I can hear someone right now. Okay. All right. So menopause is defined as the final menstrual period and is usually confirmed when a woman has missed her period for 12 consecutive months. So when you have gone a year without a period and there's no other cause for it, then we say technically that last period is menopause, and anything after that is post-menopause. So if you go without a period for 6 months and then you have a period, technically we can't call that menopause because it's that 12-month period. So menopause results in lower levels of estrogen and other sex hormones like progesterone, notably. It's a normal, natural life event that all women experience if they live long enough. And generally, women are living long enough to experience this and then live, you know, a long time on the other side in a postmenopausal state. Now, perimenopause are physical changes beginning in the years before the final menstrual period. It's a transition between your reproductive years and menopause and postmenopause. This stage can last for 4 to 8 years. On average, it lasts 6 to 7. It begins with changes generally in the length of time between periods. So that can be shortening or lengthening of the time between periods. And it can end about a year after the final menstrual period. So perimenopause is this transitional time. And very technically speaking, menopause means you've had that final period and now you're in a consistent lower hormone level state. So once again, perimenopause, changeable time between reproductive adulthood leading up to menopause, on average lasts 6 to 7 years. It can begin as early as 35 and last up to age 59. So on average, like there's more common places to see, like often if I see a woman between the ages of 43, 44, and 50, I would often assume based on what she's telling me that she's in perimenopause in some different ways. Now, you can still be having totally regular periods but be experiencing other changes. So that might be worsening PMS, sleep disruption, body metabolism related changes, all kinds of things. We'll come back to that, but you can still have regular periods and be in perimenopause. So once again, it warrants to me that whenever a woman comes to me, I'm listening very carefully to hear, I want to be aware of this. I want to be cognizant of it, and at least equip her with information about what she can pay attention to, track, start to notice, and then we can, be proactive around it. The average age of menopause, meaning the average age when women stop having those periods, is 51 years of age. But there's variability to it. So some women go through menopause earlier, some women go through menopause later. And there is also the possibility that some women are kicked into menopause by being treated for cancer and receiving chemotherapy that causes a medically induced chemotherapy. If you have a total hysterectomy for some reason and your ovaries are removed, then you will be kicked into menopause earlier. That's not uncommon that I see women having hysterectomies for other reasons, and then they're forced into that low hormone state, right? So there's variability there. I don't know if I like this term, but it's been called reverse puberty. Puberty is the time when all your hormones are first coming out and ramping up, and you're entering into that reproductive part of your life. And this is it phasing out, right? So it's a time of transition. The other things, like we're talking about, yes, it's a hormonal transition. It's also a transition from focusing for a lot of women from, their mothers, they're caring for a lot of other people in a number of different ways. Is it a time to transition from focusing predominantly on that? And maybe you can care more for yourself. I find a lot of women in this time, they're really representative of the sandwich generation of women, where you're taking care of kids or teens. You're also taking care of your parents as well. And that's a lot of stress. Like that's a lot of resources for a woman to give. And I'm just saying, I can see that as being a pressure point for some women, why they come in, and we'll talk a little bit about stress as we go through the series, but it definitely doesn't help the symptoms of the hormonal transition. I think it's a time, and I once again can't say this because I've personally been through it, but I always think there's an opportunity to think about how can you put yourself first and not feel bad about it. Women need to stop being so nice, I think, and say, no, this is for me. It's a time to learn maybe how to recognize, what are you saying yes to that is not good for you, and what are you saying no to? And I struggle with this myself. I find it really hard to say no, but I recognize how it adds pressure to me, and that can be tricky. So I wonder, and I've seen just women come in thinking about, like, I know something needs to change, but I'm not saying it's easy. It's just a time maybe to think about that. There's literally a rewiring of your bodies and your nervous systems that's happening because of the hormonal changes. And that'll make sense when I talk about what all these hormones are doing for you. But your body has to learn how to be in a state where it was estrogen and progesterone were high, and now they're way different. So they were here and now they're here. And your body it adapts in certain ways to that state. And so, it takes some time. And this is, once again, I'm like, it's a big change. It deserves support. And that support can look like a lot of different things. It can be unsettling, liberating, frustrating, insightful. It can be a real combination of things. I mentioned some of this is a bit redundant, but perimenopause can generally be thought of as the period leading up to, when I say anovulation, I mean that your ovulation is becoming less predictable and less routine. That's generally what happens at some point in perimenopause. And then menopause is when you're not ovulating at all anymore, and now you're in a consistent low hormone state. So why do I have a picture of eggs on the screen? Because ultimately, this transition is all about your eggs. Women have follicles or eggs in our ovaries, and it's these eggs that, as they naturally age, so everything in us is aging, our eggs are aging too. And as our eggs age, that is where ultimately the fluctuation in estrogen and progesterone comes from, the two major female sex hormones. So, I'm showing this textbook picture of a menstrual cycle just to remind you of, you know, a normal physiological menstrual cycle. There's these ups and downs. If you just focus on the ovarian hormone part of this picture where it says estradiol and progesterone, you can see there's peaks and valleys, right? And then there's a rise and a fall. And that corresponds with a period. This is showing you, obviously, if someone were to conceive or become pregnant, the hormones would stay high and it looks different. But this is a normal menstrual cycle. So once again, perimenopause and menopause, it's all about what's happening with those eggs. And as I say, they generally age. For some women, that aging process is younger and quicker, and for other women, it's later. So it really varies. Once again, things like chemotherapy or certain other medical treatment can speed up the aging of those eggs and our ovaries. And that's a factor for some women for sure. But yeah, we'll come back to these hormones and how they, you know, this becomes wrapped up in the question of, so can I do a test that tells me where I am? It's not super straightforward, but you know, this is where if we understand physiologically what's at play, it can help us interpret it to a degree for sure. So if you remember, there's this image, right, of a sort of two curves, two sort of peaks and valleys of estrogen and progesterone. So you can see estrogen here, it comes up, it dips, and then it comes up again. Progesterone really comes up after we ovulate. This is that normal, if we call it a textbook 28-day cycle, this is what happens every month for women. Now, when we are in perimenopause, the reality is it doesn't look like that every month. So what happens is there's a bit of a roller coaster ride that we go on, and notably, this roller coaster entails a lot of fluctuation with respect to our estrogen levels. They become less predictable. One month they can be great and high. Maybe they're too high to be on, not too high, but just higher. And then the next month they could be really low. And sometimes your symptoms give you clues around what's going on, but it's volatile. And that is due to your eggs aging. And progesterone tends to do this natural progression and decrease. And sort of, I see progesterone become the lower hormone first often, if I do test it, or just by listening to what women tell me. And this is because you don't ovulate as regularly. And you only make progesterone when you ovulate. So it makes sense. If you're not doing that as regularly, you're not going to make the same amount of progesterone. And so from a hormone balance point of view, women feel symptoms. Hormones are like Goldilocks. You don't want too much and you don't want too little. And I find if you want them to be sort of here, right? And if there's a gap that widens, that's where you feel more symptomatic. Once again, we'll talk about all those things. So often I'm listening for that. And then I'm thinking about, I know that there are tools that can help me narrow that gap again, right? So all of the changes, we played that perimenopause bingo. There can be new, heavy or longer menstrual flow. That can be a change women notice. I've seen women notice that in their 30s. I've seen women notice it in their early 40s. It's not uncommon. The biggest risk with that is that women can become iron deficient if their bleeding is heavier or longer. And so I'm always thinking about, do I need to test and treat for that? You can have a shorter length of time between your periods, which often isn't fun because you're bleeding more frequently. Sore, swollen, lumpy breasts, new or increased menstrual cramps. There can be changes in that. You can have new disruption in your sleep, on sweat. Sometimes women have night sweats, hot flashes. They might be all over the place. They have them sometimes and they go away for months, then they come back. You can have new headaches, worsening headaches that might be cycle specific or not. I see a lot of women come in and tell me that their PMS feels worse than it used to. You know, PMS are those classic, I feel moody, I feel irritable, I can feel sad or anxious, I have cravings, I feel bloated, breast tenderness. I find women can come in and be like, 2 out of 4 weeks of the month, I feel premenstrual. And that's not normal. It might be common, but it's not normal. So that can be associated with perimenopause. And once again, just those eggs aging and the hormones fluctuate because of that. There can also be the dreaded midsection weight gain that women are like, I haven't done anything differently. I'm still exercising. I'm eating the same, you know, and why is this happening? It is hormonally driven to a degree for sure. And then there can be other not so fun things: brain fog, UTIs, vaginal dryness, joint pain, acne, hair growth where you don't want it, and hair loss from your head. I mean, it sounds like not any fun at all. So all these things are possible. This diagram here is from this, it's called the Center for Ovulation Research. I have put up the website at the end of the presentation, but it's a really good resource. They're based in BC. But you can see here, so there's like very early perimenopause. You know, they're approximating that happens for 2 to 5 years. Women may not notice too much, or maybe it's that PMS that they notice changing. Then the menopause transition, they might have more erratic periods. You can see as we get later in the perimenopausal sort of stage, they might start skipping their periods. So this is where women come in and be like, I haven't had a period in 3-4 months. I'm hoping that's it. It may or may not be. It's tough. And I always say I don't have a crystal ball. I can't really tell you what's going to happen there. It's a normal part of that process. And then once again, final menstruation. Once you've gone 12 months, we would assume that you're now, that was menopause, and now you're post-menopausal. So hopefully that's made the stages more clear to you, and we'll come back to testing shortly. So we talked about perimenopause. There is a lot of overlap between the symptoms of perimenopause and menopause, and that's because it's one continuous transition of estrogen and progesterone changes. But there are some other things that, generally speaking, they might intensify or are even more common to women once they have stopped having periods. I'm just going to check my little chat here. So there's a question here about, once in menopause, do all the symptoms go away? Unfortunately not. So once again, some women might sail through and be like, perimenopause, what's that? I didn't feel that. And then, you know, oh, but I had my last period 2 years ago, and now I'm having hot flashes, and now I'm having this. So it really depends. It's so variable. And the point being is that it matters what your experience is. If you are having some kind of change in your body or symptom that is bothersome to you, it's worth bringing it to a healthcare practitioner and talking about it. And once again, I'm one of these docs that I'm like, come and talk to me about it, and we will, you know, make a plan with that in mind. So these are the core symptoms of menopause. And these are not based on these are all things that I can be like, yep, I've seen them all. These are also from like the North American Menopause Society, the different, you know, sort of medical authorities that list these things. So hot flashes are first, vasomotor symptoms. Maybe they're first because they're a common part of the experience. Sleep disruption and insomnia is considered a core symptom of menopause, which is unfortunate. And sometimes the sleep disruption is linked to the vasomotor symptoms because of night sweats, which are basically hot flashes that happen at night, and they wake you up and you're sweaty and you're hot and your heart is racing, and then you can't sleep. And that's no fun. Mood changes, low mood, depression, anxiety. Women that have experienced depression or anxiety earlier in their life are at greater risk for experiencing it when they are perimenopausal or go through menopause. So that should be understood. There are, once again, a number of ways to address it. Brain fog, cognitive challenges, like literally women are like, Bronwyn, I'm worried I have Alzheimer's. Like, it's that intense. And rarely is it Alzheimer's, but it can be so profound and disruptive that women think it is. And, you know, this is once again really due to the big drop in estrogen that you experience. Estrogen was doing a lot of good stuff in your brain. And so when it drops, your brain is like, oh, where did it go, right? It can get better with time, but it can definitely be pronounced and common. Genitourinary syndrome of menopause is this unfortunate group of symptoms that affect the urinary system and the vaginal system in women. I have a couple slides about that because I felt it deserves its own sort of information. That midsection weight gain, joint pain, stiffness, joint symptoms can be profound and associated with the loss of estrogen. Bone loss, often bone loss is not something most women feel, but bone loss is a serious cause of disability and even death in women, you know, over the age of 70. So, you know, fracturing hips or, you know, big bones, you don't want to do that. It's hard to bounce back from that. And once again, estrogen was a big factor in optimizing your bone density and bone health. And then it goes away and your bones rapidly, you lose a lot of bone mass there. So it's something that's really important to address and be proactive around, especially if women have more risk factors for osteoporosis, which you would know if you have a family history of osteoporosis, if you are of small stature generally, and maybe you've had a bone scan done to tell you maybe that there's that there. And then skin changes, so thinning, wrinkling, you know, the feeling like you want to flip gravity off, and hair loss generally, once again, from the head that is bothersome to women. So many symptoms once again, and it's so variable as far as what women experience. There's no rule that, you know, you have to experience one or all of them. Like whatever you're experiencing can qualify your menopause experience. It doesn't matter. So estrogen is the juicy hormone. And once again, I've made mention of this is why there's bone loss. This is why there's joint health problems. This is why there's brain health issues. Estrogen does a lot in our brain. It supports cognition in women. It supports sensitivity of our insulin and our blood sugar response. It also generally directs metabolically us to store fat around our hips and our bum. And so when we lose it, it's often women report that they're quick to gain weight around their abdomen or their tummy, and more fat gets directed there. That is in part under the influence of that loss of estrogen. Once again, joint and bone health, I've mentioned. Estrogen stimulates bone growth and mineral resorption, and it also stimulates joint and like collagen production and keeps things like juicy and mobile. Cardiovascular health is another one that a lot of women aren't very aware of, that estrogen is doing us a lot of favors on this front. And once again, when it steps down, women, the number one killer of women post-menopausally is heart disease. So heart attacks or strokes. It's not breast cancer, it's heart disease. So we really need to have more of a conversation about cardiovascular health in women. And I'm doing another, I think it's the third session in June, is going to be more focused on that. And then vaginal and urinary tract health, I mentioned this as well. Estrogen is like the queen hormone. She's sitting on her throne. Think of like the very feminine, like, you know, bossy, juicy, like she's estrogen. And so once again, your body, it's a big change when that goes away. Progesterone is that one that often slides first in perimenopause. She's more of the calm, collected sex hormone. She protects from overstimulation by estrogen. Estrogen is a stimulatory, growth-promoting hormone generally. Progesterone is like the yin to estrogen's yang. It balances that, and it does play a protective role in our breasts and in our uterus. That's the endometrium. That's the lining in our uterus. It strengthens and thins the uterine lining. This is why women so often can have heavier bleeding or spotting. And that's because progesterone is slipping and it shows up as that. It's very calming in our nervous system and our brain via neurosteroid effects. So it can be used to help support sleep and general sort of calm in the body. And it balances immune system activity as well. It does balance thyroid activity and supports metabolism. So progesterone is just as important as estrogen. We need them both to feel balanced and well. And once again, it's about that gap sometimes is widening for women leading up to menopause. And then they're both just low, right, after the fact. So, you know, that gap, once again, makes you feel symptomatic. So the loss of progesterone and relatively more estrogen can look like heightened PMS, more breast tenderness, more things like fibroids and cysts, right? More growth because there's not as much progesterone and relatively more estrogen. Too little estrogen is going to look like low mood, hot flashes, vaginal dryness, low sex drive, sleep disruption. It's a lot of overlap, but this is what I'm listening for when I work with women, to hear that and identify what do I think is going on relatively, because I do think women feel their best when the hormones are relatively well balanced. Just quickly to address, this is another hormone. Cortisol is not a sex hormone. It's a stress response hormone. We all have it. It's a normal part of our daily rhythm that cortisol should wake us up. carry us through the day, being sort of active and alert, and then it goes down as the day goes on and stays nice and low overnight to get us to sleep. Stress is unavoidable, right? Especially the last year. We all have stress. We all have individual stressors, and we're all making a response to that stress. And all I want to say is that the reality that I have been made aware of is that stress tends to throw extra gas on the fire that is the hormone transitions of midlife for women. So it tends to get in the way of progesterone and testosterone production, so it can just make that a bit worse. High stress tends to disrupt sleep patterns as well. It tends to affect our metabolism and direct weight gain around the midsection, and it also disrupts thyroid activity. So it can be a bit tricky to always be able to delineate with exact preciseness how much of this is stress and how much of this is just that your body, your eggs are aging, and there's this, it can be all of it, right? But I work from a place where I'm usually building plans that can address this piece, right? And can address the sex hormone changes, the estrogen, progesterone changes. So just want to make you aware of this. And we're going to talk about it more at the next session. I put up a picture of the thyroid. This is the thyroid gland, which sits here on your neck, because a lot of symptoms of thyroid imbalance can mimic perimenopause symptoms, notably like feeling tired, feeling cold, feeling bloated, gaining that weight. I will make the point here, and it's included in my slide about testing. I do tend to run a lot of thyroid blood work just to understand, is this also getting in a woman's way? Is it contributing to her symptoms? The thyroid is, the reality is it's a very sensitive little barometer for any other stress in your body. So it's not uncommon that it's affected by the changes in estrogen and progesterone. And sometimes it requires specialized overt treatment. Maybe someone here is already like, well, I take Synthroid or I take medication for my thyroid. That's not uncommon. And then some women might need to initiate specific support because of the sex hormone changes. So it's important to be aware of. I include it as a part of a lot of my baseline assessment for women to understand how this might be affected and just make sure that we're on top of it. I want to make a note about autoimmunity in relation to sex hormone changes in women. Women are far more likely to develop autoimmune conditions than men. And there's been a lot of research trying to figure out why this is. Is it genetics? Is it hormones? We generally, once again, there's a very strong female predominance for things like rheumatoid arthritis, lupus, Hashimoto's, which is an autoimmune thyroid disease, Sjogren's, even multiple sclerosis, more women than men. The research does suggest that in general, lower sex hormones can aggravate existing autoimmune conditions and may lead to changes in general immunity that might trigger autoimmunity. My understanding, my appreciation is often that I feel like there are other factors at play. It's not just hormone related changes that we can say that's it. That's why we can, that's what we can blame autoimmunity on. It's usually not that simple, unfortunately. There's usually other things going on, whether it's in the gut health, maybe there's chronic stress, viral exposures or environmental exposures. I have to think about all that big picture, but I do also think about when I see women of a certain age, how their hormones might be rolled into it and maybe either fueling it, right, or certainly not helping them feel better. So something to be aware of. Okay, hot flashes. We talked about this being the core symptom. Up to 75% of North American women experience them. Hot flashes are that hallmark symptom. Why they happen, we actually don't really know, but it has something to do with the brain's temperature regulation center, and we know that low estrogen is definitely a factor. Night sweats refer to hot flashes that disrupt sleep. Ways to tackle hot flashes if you are experiencing them or night sweats. Hormone replacement therapy works great for hot flashes in a lot of cases. We're going to come back to hormone replacement therapy, but I would be amiss if I didn't put that on the list. Hormone replacement therapy means giving women sex hormones. And that, once again, is probably the best studied treatment we have for hot flashes. You can do nothing about them. Hot flashes can get better with time. There's a small group of women that will always have some degree of hot flashes for the rest of their life once they go through menopause. but it's more common that women experience them for a period of time and then they go away and they're not really remarkable. But I see a lot of women where these are intense and like they're really disruptive and they happen at least every hour and they're full body soakers and like they feel like they can't go anywhere in public and they sweat through their clothes and like it's brutal. And so to me, I'm like, well, we got to do something about that, and we can. SSRIs are, you might be like, oh, isn't that for treating depression or anxiety? It is. They are also used to treat hot flashes. They don't work as well as hormone replacement therapy, but they are a non-hormonal option. Some women, I've seen them be prescribed. Phytoestrogens are plant compounds that look a bit like estrogen. They include soy, ground flax, lentils, different legumes. They have good research to support their ability to reduce the intensity and frequency of hot flashes. They are not estrogen. They look kind of like estrogen, which means they bind at our estrogen receptors and can stabilize that low estrogen state. So there is often a lot of questions around, oh, I heard those increase cancer risk, or if I have a personal history of cancer, I should avoid them at all costs. It's a myth. There's no research that says phytoestrogen intake increases any kind of female cancer risk. In fact, in countries where they eat the most amount of these foods, they have the lowest rates of female hormone-driven cancers. So I'm a big believer in phytoestrogens. I try to eat them myself for my own sort of hormonal health, but they're definitely something to be aware of. And I would say like daily consumption is great. I'm going to sound like the fun police here, but alcohol does not ever help hot flashes, especially before bed. It never helps with sleep either. Sorry, ladies. Caffeine doesn't help. Spicy foods don't help. Literally, like hot temperature foods don't help. So you want to be aware of that. There are herbs and supplements that some women come into me and they're already taking, and they're like, yeah, it definitely helps a bit, right? But they're still there. So there are options, and these are going to be non-hormonal treatments that some women opt to go for. The other tips I give are try to go for like cotton bedding and like pajamas, like not synthetic fabrics, because they're a bit more cloying, especially from a night sweat point of view. I find heightened stress will never make this better too. So having, understanding how much that's playing a role is important. And the blood sugar thing is kind of related to that stress piece. Like if you're skipping meals and then you're super hungry and irritable, you're more likely to have a hot flash. It just depends. Okay, just keeping an eye on time. I'll probably go right up to 1, and I hope that's okay. We still got 25 people on, so I'm just checking the chat again. Is soy contraindicated for people with thyroid issues? No, I would say that's not an absolute contraindication at all. I know if you Google it, or you might see a lot out there about don't eat soy if you've got a thyroid issue. There's absolutely no real clinical research that's ever told me that that's really an issue. And I would say the caveat would be, if you know soy is bothersome to your stomach, or there's a reaction you have to it, then obviously you might need to choose some of the other phytoestrogens, but there's no hard and fast rule around soy for people with thyroid issues. Just like there's no rule around things like broccoli or Brussels sprouts. You might have heard of that too. That's a myth. Okay, genitourinary syndrome of menopause. This was coined this in 2013, not by me, by doctors. Of all the symptoms of menopause, it will not get better with time. It needs to be treated. So hot flashes can get better with time. Mood changes can get better with time. Even sleep disruption can get better with time. This will not get better with time. And it's a big problem. And women are afraid to talk about it. And often women are like, oh, I just have to live with that, right? So you can see it's everything from dryness, burning, itching, irritation, bleeding. Sexually, it's painful sex, any kind of pain with vaginal penetration, reduced lubrication, feeling like the Sahara down there, decreased arousal, like, no desire for sex. That can obviously be wrapped up in it. If it hurts, you're not going to want to have sex. And urinary symptoms can be frequency, increased urgency, urinary incontinence, so that pee when you sneeze thing, or laugh, or, jump or walk, whatever it is, common. And recurrent UTIs are another issue I see. So women coming in and they're like, ever since menopause, I keep getting UTIs and I keep getting put on antibiotics. This is due to the drop in estrogen that is normal, and it really affects this part of your body. Estrogen was keeping everything juicy, and it was regulating the bacteria in the environment. And so this needs to be, we need to stay on top of this. Up to 84% of women experience some degree of this syndrome. So a lot of things going on. It's because of estrogen. You can see, just if you just look at this comparatively, it's like nice, plump, thicker tissue, and then it gets thin. And we also lose all those, the vagina is made up of all this rugae, which is kind of like tiny little folds and things like that. And it just gets flat and thinner. You can see it. And I do Pap exams here, and I can see thin, less sort of healthy tissue when I do those exams. And often women are like, I hate these exams because they hurt. And that's unfortunate. So the treatment, to me, I believe it requires assessment. That might be an exam, but also just listening to a woman's symptoms. There's foundations to think about, like diet, what's going on with the local immune system, overall hygiene. We need to heal the tissue. We need to lubricate the tissue. So ladies, you need to consider lubricant. I recommend water-based. And just be aware that whatever you use, if it throws you off down there, so you would know it if it does, then you got to find something else. Vaginal moisturizers are literally like, think of them like cream for your vagina. And there are things like hyaluronic acid that are pretty well studied, vitamin E, vitamin A. These can all be put together. And there's over-the-counter products like Replens. Gynotrop is another one. These are vaginal moisturizers. They can help quite a bit. So they're not lubes. You don't just use them if you're going to have sexual activity or any penetration. You want to use them consistently. We're trying to build back and heal that tissue. Vaginal estrogen replacement is very, very helpful and valuable, and often a very safe option for a lot of women. So we're locally applying estrogen, and that literally helps. The root cause of this is low estrogen. So we're really addressing the cause here. And I'll come back to the safety around it. It is a form of hormone replacement therapy that is not systemic. So it's only very local, right? When we want to treat hot flashes, mood changes, sleep disruption, we're going to use systemic hormone replacement, which meaning it's throughout the whole body. This is just local, and it works great. There's also pelvic floor physios that I refer to, and that's often if there's a lot of the urinary symptoms. I do feel like there's a component of strengthening and awareness around the pelvic floor muscles that can be really valuable. And there's some great local pelvic floor physios. And also it's worth mentioning that regular painless stimulation improves blood flow. And so that's helpful too. But it's just this vicious cycle where women are like, nothing feels good down there. So there's nothing happening. I have no desire. And they just think it's totally normal. And this will not get better with time. So I'm really passionate about helping women with this one. Bit about testing. I do a lot of baseline testing. I encourage women to track their cycles when they're still having periods. There's good apps noted here like Clue, Flow, Candara, even just pen and paper. This can give you more information about, oh, wow, my cycle length is changing. Oh, wow, I am having more PMS. And then you can bring it to your healthcare provider and say, look at this. This is different for me. Anything that's different for you is worth a conversation about. So tracking is important. There's no test to diagnose perimenopause. The hormones are too volatile. Remember I told you, like, estrogen's on a serious roller coaster. In general, we know that progesterone is doing a bit of a steady decline, but there's no official test to diagnose it. We have to listen. And sometimes I'll use hormones to confirm it and see the relativity between them, but there's no routine need to test anything here. Follicle stimulating hormone is a blood test that's confirmatory of menopause. So if we have a woman with an FSH of over 30 and she hasn't had a period for 12 months, all it tells us is, yeah, you're through it. You're post-menopausal now. So it's not a necessity, but often I've had women go, I asked my doctor to check my hormones and this is what they test. So it's not uncommon. And once again, serum estradiol and progesterone can be tested. What I tell women, if they come in to see me and they haven't had a period for a year or more, I tell them the value in this, there's not really value in this because they're just going to be low. I know they're going to be low, right? Sometimes I'll do blood work as a baseline way for me. If I know that woman wants to take hormone replacement, it's going to help me track over time how her levels are changing, and if I'm doing that in step with where I want to be. So the other tests here, and once again, this is why we're recording this and we'll send it out after. I do a lot of other testing because I believe a lot of women come to me and there's other things we want to be aware of. Is she also iron deficient because of more frequent bleeding and heavy bleeding? You know, what's going on with her fasting blood sugar and her blood sugar control, her thyroid I mentioned. Nutrients like vitamin B12, your vitamin D. Vitamin D is a huge one from a breast cancer risk and heart disease risk, cognitive health. It's a hormone. Vitamin D functions as a hormone. So checking it is a really good way to be proactive about your health. Bone health as well for vitamin D. I check it pretty much with every patient I see. Cholesterol panel, other sort of cardio health tests, which will come up more in the third session we do, but I do a lot of those because I want women to understand, like, here's your baseline on this, and this is how we're going to track it, right? And be proactive around your health in this way. PAPs, I just wanted to make a note about Pap Smears, everyone's favorite test. We do recommend they're continued every 1 to 3 years until at least the age of 70. And then some women choose they want to keep doing them. Some women stop. But you do have to keep doing PAPs after menopause. It's worth making note too of mammography. I'll refer you to this website, the Canadian Task Force. They have the best outline of the recommendation. They used to recommend mammograms starting earlier, like 40 to 49. They don't anymore routinely because women's breast tissue is dense and it leads to more false positives. So now 50 or over 50 to basically 74 every 2 to 3 years recommended screening. Bone mineral density is how we see how thick your bones are. So, and risk of fracture risk. I do think that's an important test for women, especially if they've gone through menopause. And then transvaginal ultrasounds are often, they're not routinely done, but if women are having really disruptive bleeding, or if they go through menopause and then they develop bleeding, you know, let's say 2 years after, we always have to rule out cancer, and that would require an ultrasound. So these are other tests that sometimes I'm talking about with women. I'm going to skip through this in the interest of time. I usually mostly do blood work. There are urine hormone tests. There are saliva hormone tests. It just depends on case by case, but there's no rule. There's no sort of gold standard for testing here. It just depends on what a woman is experiencing and what the goal is. So blood work is my top of the line sort of thing that I go to first. And once again, urines and saliva can't tell us things like vitamin D and thyroid and your heart health. So that's why blood work is so great. We're going to talk more about stress and sleep. In the third session, we're talking all about the weight gain and what you can do about it. All these things are going to come up again. So in the interest of time, I included those slides, but we're going to hold off until May and June session to tackle that. I want to sort of wrap this up with a bit more information about hormone replacement therapy. So hormone replacement therapy, that's what HRT stands for, or hormone therapy. That's giving hormones to women that are either perimenopausal or post-menopausal. It's been used for a long time. It's been around for a long time. There are literally hundreds of studies confirming that systemic HRT, so estrogen and a progestogen, help improve quality of life for women in reducing their hot flashes, night sweats, vaginal dryness, bone loss, as well as another big one that we've known for a long time. HRT will help mitigate bone loss or slow it. There's more and more studies indicating hormone therapy supports joint health, mood and cognition, so that brain fog piece, and sleep directly. There's both old and new research recommending the use of hormone therapy to mitigate the risk of cardiovascular disease in postmenopausal women and dementia. So there's been long-term studies looking at rates of dementia in women that take hormone replacement versus not. And women that take hormone replacement are less likely to be diagnosed with dementia. And when hormone therapy is started close to menopause, it also decreases the risk of colon cancer in postmenopausal women. So there's tons of research around HRT. Now, in 2002, there was a big study published called the Women's Health Initiative. And it was like billions of dollars. It was done over like 2 decades. It was published in 2002. And that study caused a huge retraction in the use of hormone replacement therapy in conventional medicine because the study indicated an increased risk of breast cancer in women that took estrogen and progesterone therapy. So what 1.24 to 1.26 relative risk means is if you had a relative risk of 1, there's no increased risk. If you have a relative risk of less than 1, it decreases the risk. But over 1, that suggests that there's a 24 to 26% increased chance of a woman developing breast cancer in some amount of time after she initiates hormone replacement therapy. There also suggested an increased risk of stroke and blood clots in women receiving this therapy. So once again, these risks were both higher in women. They were higher in women over 60 that initiated hormone replacement therapy. So it was lower or not statistically significant in women under 60. And it was also higher risk if women started hormone replacement therapy 10 years or more after their menopause, their final period. So maybe they never took hormones and then they're like, can I start them now? We still know that there's a bit more risk if there's a gap between you starting it. And the risk is heightened really for the first year, and it's specific to an increased risk around having a clot develop, but it's still there. Now, this study was big. It has come under since 2002 when it was published. It's been scrutinized and gone over. Even some of the authors of the study retracted their statements around it. Basically, this ended up in black boxes being put on every form of hormone replacement conventionally, saying this causes cancer and heart disease. Don't give it. So a lot of doctors were like, nope, no more. We're not doing this anymore. And a lot of women were taken off their hormones because of this study. So it scared a lot of people. And since then, what has come to light is that there were a lot of flaws in the study. And so these numbers that they put out are actually not accurate. The risk is not as high as they said it was. They didn't control for a lot of factors, like a lot of the women in the study were very overweight. A lot of the women in the study also smoked. A lot of the women in the study also had diabetes. And what's tricky is, like, how can you say that this is just related to giving women hormones? Those other things are huge risk factors as well, right? So I'm saying all this to you because HRT should be an informed conversation. I can't tell you it's a no risk treatment, but it's not as high risk as we've been led to believe for a lot of women. It needs to be evaluated properly. So there is bioidentical hormone replacement. That means it looks exactly the same as the hormone your body makes. So this is estradiol. Estriol is the form of estrogen often given for local vaginal application. It's a weak form of estrogen and it doesn't have any systemic sort of carryover. Progesterone is bioidentical. A point lower down here, like conventional medications are estrogel, estradot, Vagifem, you might have heard of these. These are bioidentical. They're prescribed by doctors, but they're not synthetic. They look exactly the same as your hormone. The research in that big Women's Health Initiative study that suggested all the risk were specifically the research was done on women taking Premarin or Prempro. And these are hormones derived from pregnant horses' urine. And I'm not saying it's good or bad. It just is what it is. It's not quite the same as us. And so it's kind of hard to extrapolate, like there was that risk. Does that mean it's the same risk for every other form of hormone therapy? Because there's so many different kinds. Unfortunately, there's not a lot of research yet on bioidentical hormones, efficacy and safety. There's some, but there's just not the same amount that was done on like Premarin and things like that. So it's not routinely recommended by a lot of doctors. That is the only form of hormone therapy I can prescribe at this time as a naturopathic doctor in Ontario. So yeah, I use it. And, you know, I'm using the best research I have available. And if a woman comes to me and she's already taking hormone therapy, then I just want to have an understanding of what she's using, right? So there's so much variability when it comes to this. There's a lot of options. I just want women to have someone they can have a conversation around this with. There's also a note around the women in the study were swallowing their hormones most of the time. And there's a big difference between when you swallow hormones and apply them topically. So creams or gels or patches really lower the risk of strokes and blood clots, because when you swallow hormones and they go through your liver, they actually activate the clotting cascade. So the same risk with birth control pills in younger women. If women taking birth control also smoke, there's a huge increased risk in their likelihood to throw a clot. So it's because hormones activate that. So once again, route of administration can make a big difference. Just some myths. HRT should not be given to women with a family history of breast cancer. That's not an absolute truth. I know women are scared about breast cancer risk and hormones. It's not uncommon. And once again, if there's just a gut feeling that like women are like, I'm not willing to take the risk, once again, the risk that study suggested is not, it's not as high as they said it was. That's been retracted since. It's a lower risk. And there are other things that are a higher risk for breast cancer, like alcohol consumption and smoking, way higher risk than taking hormone replacement. So this is not an absolute contraindication. Myth that HRT is only beneficial for severe symptoms. HRT can be used for mild to moderate symptoms. Once again, women might not feel their bone density slipping, but HRT is indicated and very helpful for that. So it's not just for severe symptoms. HRT is not helpful after menopause. That's a myth. It is helpful after menopause. Once again, slightly increased risk profile for women that have gone 10 years or more and they want to start HRT, but it doesn't mean it's totally out of the picture. What I tend to recommend to those women is they should have testing done to look at their arteries around their heart to make sure they're not at risk for a clot, because that's the biggest risk. And if everything looks good there, then often I would say it's worth exploring. The last myth is HRT is not for women who enter menopause early. That's a myth. The earlier women enter menopause, so maybe they took chemo or they had a hysterectomy, I would argue they need it sooner and longer potentially, because they're at more risk for more complications of being in a low hormone state for longer. And the last one, HRT should only be given for a short period of time. So there's often this suggestion, only take it at the lowest dose for the least amount of time. That's been retracted by even like the North American Menopause Society. We say now that, you know, depending on women to women and a conversation that she understands the risks and the benefits, you know, taking HRT for a longer period can be the best protective thing for a woman's longevity and quality of life in the long run. So it's not an absolute. So it's a very personal decision, like getting vaccinated, like, you know, any other medical treatment. It should be informed. It should detail benefit and risk in the context of your individual factors. So I'm going to sum things up here. We've talked about perimenopause, menopause, the symptoms, what the hormones are doing, HRT. I feel like we've covered a lot. As I say, in the next sessions, we're going to get into sleep and stress and brain health more and what you can do. And then we talk more about cardiovascular health, bone health, and HRT is going to be peppered through it as well. More information there. So while the laundry list of symptoms makes you be like, this is just like a cruel joke, or it's like a design flaw, it is a normal part of a woman's life. It's just that the reality is, I think there's a gap in our healthcare system that is not acknowledging women are going to live a long time in this state. So we should do more for them. That's my belief. The midlife transition does not have to be synonymous with suffering. There are a lot of different options. And it doesn't have to be hormone replacement therapy. There are a lot of other things that sometimes women want to explore first, but at least I'm giving them options. Don't settle for fine or normal. Don't settle for, it's just your age. It's just cause, right? I would say hormone literate or menopause literate health professionals want to help, and they have solutions. I believe these women, you are holding up the world, and you are capable of amazing things if you feel well and feel your best. And so, as I say, if I can help with this in my own little way, I'm going to keep doing it. These are some of my favorite resources. These are books. Estrogen Matters was written by some doctors. It really goes through that Women's Health Initiative study and what has come to light since, and sort of really breaks down the research around hormone replacement therapy and the perceived risk. These are all great. The North American Menopause Society has a great website. There's lots of resources there. I've summarized here the next 2 workshops. So I think you need to register again for those, but they're going to happen, you know, the first one May 10th and then June 7th. You can see we're going to dive in more to these specific topics. And I'm looking forward to that. And they need more time. And I don't just want to keep talking at you forever and ever. So we're going to split it up. So I'll leave this here and check the questions. Other resources are a menopause literate naturopathic doctor. I'm one of them, but there's lots of them out there. A menopause literate MD, there's lots of them out there. You can actually search for practitioners that are members of the North American Menopause Society. I'm listed there by going to that website, menopause.org. SEMCOR is a great website as well. And then there's these books that I've put down. The other ones were the Estrogen Matters. I really like that book. My email is, that's actually the website, but my email is, it's bhill, BHILL @stonetreeclinic.com if you want it. And yeah, I will leave it there. That's your menopause, perimenopause, menopause 101. I'm going to check the chat here and I'll take any other questions. Okay, I'm going to scroll back up here and see. This one I saw. Can we access slides to read later? Yeah, you for sure can. I know I covered a lot. Sorry. I could talk forever about this, and I realized that our brains can't take it all in. So yes, the slides can be made available. And this is being recorded, and then they're going to put it up on YouTube as well. I'm going to suggest if you want the slides, take note of my email, bhill @stonetreeclinic.com, and send me an email, and then I will bump you the slides, okay? The soy, so would you recommend hormone replacement therapy for someone that is 60 and perimenopausal? Do you recommend taking menopause or total body okay, I'm going to come back to the question about HRT for someone that's 60 and perimenopausal. So that's definitely older than average to be perimenopausal. So I'm not sure, I would have more questions around like, so are you still having a period or a bleed? You can give hormone replacement therapy to women in perimenopause for sure. We often just time it more cycle specific instead of sort of all the time, which is what other post-menopausal therapy looks like. So it just depends once again on what your experiencing is, but there's no hard and fast rules around HRT being only used after menopause. It can be used before. It just looks a bit different. And so once again, I'm a naturopathic doctor with prescribing authority, which means I've met the standard and taken training to be able to prescribe certain hormones to women at different stages. Do I recommend taking total body collagen supplements? Collagen's having a bit of a moment, and I don't think it's totally overblown. Collagen, I mean, we're all made up of collagen. I think if it's a good supplement, I've definitely had women tell me that they feel it makes a difference with their skin, their hair. We have a joint specific collagen here and not affiliated. There's no sort of kickback for me, but it works well. And I find women are like, oh, my joints feel better. So it might be a fit. It's worth considering. You can ask me more about it if you want. How do you know if you're in menopause if you've had a full hysterectomy but kept one ovary and are having symptoms of perimenopause? That's a good question. So sometimes women have an incomplete hysterectomy, which means their uterus is taken out, but their one or both ovaries sometimes are left. So that means you're not bleeding anymore. So you don't have that bleeding manifestation or a period. In this scenario, you will want to track more, like you want to just get a really good sense of like track your mood, track your energy, track breast tenderness, anything, and see, is anything sort of cyclical, right, in nature? Can we see some sort of a pattern from it? I do this with my patients quite a bit. Sometimes might be a case where I will use hormone testing quicker so that I can identify where a woman is at in this process, especially maybe if you're like 49 or 50 and you're just like, I don't know, right? Because I can look at estrogen and progesterone or even that FSH and tell you, you're not there yet or you're there likely. So it depends on how you're feeling and what you're tracking, and maybe a bit of blood work will help you there. So that can be tricky because you're not having that period anymore. Okay. Have you got any recommendations about managing in the workplace which could be good to share around. I'm guessing that might be around hot flashes. That's a good question, because they are very obvious, right? And I know that women feel really self-conscious when they're having them. Yeah, it's tough. I feel like it depends on the woman and how, like, does she want to be like, sorry, I'm just having a hot flash, I'm just going to own it, right? Not a lot of women probably want to do that. Once again, I would say, yeah, are these considered an inevitability? What I know is that there are a lot of different treatments that I can recommend that help women have them far less, and that the intensity is way less. I would really try to be mindful around stress and not throwing more fire on it that way. So don't skip meals and be really hungry. Try to stay well hydrated, right? Just basics like that. That will never help it be better. But yeah, it's a tricky one. It's a tricky one because you can, you can feel really uncomfortable when it's happening in front of other people, for sure. Okay, any other questions? I'm gonna ask you to direct it to my email for sure. So bhill@stonetreeclinic.com. This has been recorded, so it will be reposted, I guess, on the Collingwood through the YouTube. Lori, maybe I'll let you speak exactly to that, but I will leave it at that. And I'm really glad and appreciative of everybody that came today. I couldn't see you, but thank you for coming. And I hope that you can make it in May and June, and we'll continue the conversation.
Thanks so much, Dr. Bronwyn Hill. That was so informative. Yeah, fascinating. And there's so much more to talk about, as you said. So I hope everyone can join us for the next two. We will post this on our YouTube site. What we do is just go through to make sure for privacy, there's no one's names or anything like that. So it takes a little bit of a process to ensure for privacy. And if there is any of that, it will go to a voice recording, and then Bronwyn will have the slides. So we may switch the format next time to webinar. And I think that's it. So thanks everyone for joining us, and feel free to reach out to Dr. Bronwyn Hill or the library if you have any more questions. Thanks very much for coming today.
Thank you. Bye for now.